calm down. It's only me.
Yeah. Yeah. We're ready? Okay. Good morning, everyone. My name is Serena Cawley, and this is Brian Pratt. We're senior students from Barry University, and we presented this presentation to the anesthesia department last week on enhanced recovery after surgery, and so we're asked to present it to PACU as well, and maybe people in pre-op are interested in seeing this. There's techniques out there, scientific-based practices that have shown that some things that we're doing may not be beneficial to the patients, and that there's new ways of doing things that will help get patients out of the hospital quicker and less money, and so everybody's happy. Anyway, we'll go ahead and start. So this is ERAS, Enhanced Recovery After Surgery. So what is it? These are protocols that are multimodal perioperative pathways designed to achieve early recovery after surgical procedures, maintain preoperative organ function, and reduce the stress response following surgery. Some of the key elements of this are the preoperative counseling, optimization of nutrition and hydration, standardized analgesic and multimodal pain management programs, and early mobilization. So these protocols have become an important focus on many surgeries, including vascular, thoracic, breast, colorectal, and the implementation of these protocols have been shown to reduce complications, improve cardiopulmonary function, and reduce the hospital length of stay. So these key points are the counseling, preoperative nutrition, avoidance of preoperative fasting, carb loading up to 2 hours preoperatively, multimodal anesthetic and analgesic regimens, adequate PNV prophylaxis, normothermia, goal-directed fluid therapy, and early mobilization. So here's a flow sheet of kind of what happens to a patient when they come in for surgery. They start in the pre-hospital phase where they get education in the surgeon's office. They talk about the plan, what's going to happen. Once they come into pre-op, and before they come into pre-op, they have to limit their fasting, light meal up to 6 hours, carb beverage up to 2 hours pre-op, and use of regional anesthetic, block placement, epidurals, and then discharge planning and medication plan for pain management. So in the intraoperative phase, that's where anesthesia kind of comes in with using opioid-sparing multimodal analgesia, normal bulimia, normothermia, normal glycemia, and preventing nausea and vomiting, avoiding tubes and drains like NG tubes, OG tubes if we can. Post-op, coming into PACU, again, multimodal analgesia is a key element in this to prevent nausea, vomiting, and either no or judicious IV fluid management. Always education. And this helps with the post-discharge phase as well. So every phase of this timeline is important, and things that we do in the preoperative phase has an effect on intra-op and post-op and for discharge. So everything kind of falls into a place here. And every person's job in here is important to getting the patient out quickly. So preoperative counseling, this includes the pre-op admission testing where the anesthesiologist talk to the patients regarding their pain management and what's going to be expected. Not everybody is going to be a candidate for this. Are they going to be medically optimized? Are they going to follow these directions? Are they going to be able to say, yes, I will stop eating at a certain time? A light meal to them might not be a light meal to us. Carb loading 2 hours preoperatively doesn't mean going to IHOP and getting the all-you-can-eat pancakes. And what are their pain management expectations? Are they opioid tolerant? Sometimes we have to use different medications that don't use the same receptors as opioids. So that's definitely a consideration. So nutrition, current fasting times are not evidence-based. The preoperative fasting was introduced to help reduce particulate matter in the stomach and aspiration pneumonitis, but studies showing that there was no difference in gastric volume or pH between patients fasting from clear liquids, the standard 8 hours versus 1 hour prior to anesthesia. So the guidelines recommend continuation of carb beverages up to 2 hours prior to induction of anesthesia, and this has been shown to reduce insulin resistance, minimize nitrogen and protein loss, maintain muscle strength, and accelerate recovery, and help reduce the stress response. And a lot of people do come in with a lot of stress preoperatively. They want to know, when is the last time I can have anything to eat or drink? Can I just have water? Can I have ice chips? Can I have anything? And then the other question is, when can I eat again? when will I be able to eat? So this is, the nutrition is something that is very stressful to patients. And again, diabetic patients or patients with gastroparesis, that might not be an opportunity for them to have meals up to 2 hours prior to anesthesia or carb beverages. So, Ryan?
Right. So now we're going to talk about perioperative pain control and some of the recommendations by ERAS. And what this is what they're recommending is that we do either opioid-free anesthesia or we use different medications to help prevent or minimize the amount of opioids that we use so the patients have a faster recovery. So we're going to just review a couple topics so you can kind of see how we can still reduce the opioids we give, but just give them at more of a better time so they can still have the same level of pain relief from opioids while giving less opioids together. So pain transmission, pain you're feeling, so if you get like a prick in your finger, you have nociceptors there, and there's 3 different nerve pathways that take it up, or synapses. So you can see you get stuck here, it follows up one nerve, it synapses at your spinal cord, and it's taken up to the brain where you actually comes into consciousness. And this is the synapse there in the dorsal horn of the spinal cord, the area called the substantia gelatinosa. You can see in addition to mu receptors, there's a bunch of different receptors here that we can kind of target in order to prevent pain, not just opioids, but things like NMDA receptors, prostaglandins, substance P. This is just kind of a demonstration of the dermatome. So the different nerves that come off the different levels of the spinal cord, you can see it kind of go out and innervate specific areas. When we're doing like epidurals or spinals, we can kind of go up and down on our level in order to target specific areas. Or if we're doing a regional, we can block the nerves up here in order to provide anesthesia to the arm. And those techniques are a lot easier to do opioid-free anesthesia with. Obviously, we can give them a block here, block them for 24 hours, and they don't have to get opioids intraoperatively. Mechanism of action. So opioids, they work on mu receptors as well as a bunch of other different receptors. But what we want is the mu1 receptor. It's G protein, and it blocks the response or the afferent pathways of the pain as they go up the spinal cord. This is just kind of highlighting the different receptors. And once again, we just want to target this one, but unfortunately the opioids are non-specific and they kind of go everywhere. So this is just kind of the side effects you'll see. So mu1, we have the analgesia, and then you get into some of the others like mu2, you get the respiratory depression, the kappa, you'll get the dysphoria that some people experience. So anesthetic techniques. So we can minimize our opioids by just giving them per se on emergence. So they're going through the anesthesia. We can do general anesthesia where they go all the way to sleep. We put a breathing tube in. Regional anesthesia, these are the nerve blocks, as well as the epidurals and spinals. So just cover general anesthetic. When we do it general, it encompasses 4 different things: is paralysis, amnesia, analgesia, and sedation. Typically we do this with our inhalational agents. They're extremely potent. Just a given, if we're going to do a TIVA instead of our gases, we'll actually use doses of propofol up to 300 mics per kilo per minute, in addition to a remifentanil drip up to 1,000 mics per hour, and that's the same potency as regular fentanyl. So you can see we have to give a ton of IV medication in order to achieve the same effect with our gas. So stages of anesthesia. So we have induction, and then we have our maintenance phase, and then emergence. What PACU sees is kind of the emergence phase. So either we emerge them in the OR or they come out in a deep state and they'll emerge in PACU. And what we can do, as opposed to giving opioids on induction and in maintenance when they can't actually feel pain, we can do opioid sparing through these parts and just give opioids when they're waking up. So it's just a little bit better targeting. This kind of goes through the different stages of anesthesia again. When we're doing surgery, they're at stage 3, and so it's a very deep state, and our gases work in the brain and the spinal cord, so they can't actually feel pain while they're underneath the general anesthetic. So typically when we start our anesthetics, we give patients a big dose of a hypnotic, propofol, anywhere up to 200 milligrams. Fentanyl 100 mics, and lidocaine. You'll see these usually at the beginning of all our anesthetics on our charts. Why we're actually giving fentanyl here is not to block the pain response per se, but actually to block the sympathetic response to laryngoscopy. During maintenance as well, we often give fentanyl, you'll see throughout the case. And once again, this is at a time when the patient can't actually feel pain. So what we can do is we can do opioid sparing during our induction phase and our maintenance phase. And then as the patient's waking up on emergence, we can give either fentanyl or long-acting opioids. And we usually titrate this to the respiratory rate while they're still intubated. That way we can spare the opioids here, and then they come out still comfortable with opioids on board. So multimodal, obviously when we're deciding what we're going to do, it's based on the patient and the type of surgery we're doing. If we're doing something like a thoracotomy in a very innervated area, opioid-free or sparing is not going to be completely achievable unless we're doing an epidural block with it. And then the patients, if a patient has a history of bad cardiac disease, the opioids are actually very cardiac stable. So instead of giving a big hypnotic dose of propofol or a gas, we can give opioids and less than that so the patient's more stable during the procedure. So opioid-free anesthesia is just what it says. It's just anesthesia without giving opioids. It's for a selective group of patients. So it's easier to do on patients that are going to get some type of regional, or if it's more of a small or minimally invasive surgery where they can localize real well, then we can do no opioid and do things like Toradol and blocks. This kind of goes through anesthesia again, which we already covered. Traditionally, so what we used to think is that by giving opioids before patients are having pain, we prevent more pain later. Unfortunately, what we're finding now is it's actually a 180. When we're giving opioids before the patient's having pain, or just kind of giving them for a sympathetic blockade, we're actually causing more pain later, which is why this is kind of coming about with the ERAS. So unwanted effects of opioids. So they cause what we call hyperalgesia, which we'll cover in just a minute, respiratory depression, which we all have seen, both centrally and also the muscles of the upper airway and larynx. So oftentimes you'll see patients come out with airways, and that's because the muscles are all just depressed, so they don't have that muscle tone anymore, and they get dynamic collapse when they're inhaling. Post-op nausea and vomiting, dizziness, constipation. GI dysfunction. This is a big part, and it's kind of a big part of ERAS in total. So what we want is the patient to come out and start eating and drinking as fast as possible in order to kind of get recovering faster. What the opioids do is they cause smooth muscle contraction, so the sphincters along the GI tract and also the urinary tract that cause retention. In addition to this, they decrease GI motility, so they cause constipation, which we've all seen, and all the food and water will start backing up in their stomach. They won't be able to consume anything. For the bariatric surgery, this is especially important. A lot of bariatric surgery now for the sleeves and Roux-en-Y's, they're doing opioid-free anesthesia with drugs like Precedex. And that's because for these patients to be discharged home, they actually have to meet fluid requirements, or they have to consume X amount of fluids before they go home. So by giving less opioids, these patients can go home sooner and they can start hydrating themselves again. So some of the effects of opioids: desensitization. So this occurs within minutes to hours, and what it is these opioid receptors will actually start what we call downregulating, where they go back into the cell, and so then we have to give more opioids to achieve the same effect. You have tolerance. This is when patients come in, they've already been taking opioids, and obviously in order to achieve the same effect with someone who is opiate naive, we have to give higher doses. So hyperalgesia, this is a state of not sensitization or desensitization, but when a patient actually experiences more pain after getting more opioids. They were seeing this in patients. The more opioids you would give throughout, say, the maintenance phase when they're on a Remy drip, getting 1,000 mics over a couple hours, that these patients actually had more pain post-operatively. And what they did to kind of identify this is they took healthy volunteers into 4 different groups, receiving low-dose fentanyl or remifentanil and high-dose fentanyl or remifentanil. And then after these drugs were completely out of the system, 6 to 8 hours later, they would test their pain scores to either cold pressor pain or electrical pain. And the patients that got the high-dose fentanyls had actually more pain afterwards. This was a study here. Basically what it is it's 3 different groups. For general anesthesia, they had an ESMAL group, a fentanyl group, and a remifentanil group, and then they measured the post-operative opioid use and the post-operative pain. The ESMAL group, it's of course, is the beta blocker that received this instead of opioids intraoperatively, had less pain and less opioid consumption later. Oh, there it is. So you can see it just kind of shows you by not giving opioids during our maintenance phase when they're not actually perceiving any pain, can decrease their pain later. This covers the type of patients we select for it. So patients that want bariatric surgery, morbid obesity, sleep apnea, chronic pain, or severe nausea and vomiting, we can try to minimize or do opioid-free anesthesia for. Contraindications, these are patients like our cardiac cripples, autonomic dysfunction, heart block, or the elderly. So we're going to talk about some of the drugs we use, which a lot of you guys already see. We have the anti-inflammatories, which are the steroids, NSAIDs, and local anesthetics. The others, Precedex and beta blockers, and then the ones that work on glutamate. So many of the drugs that work on glutamate are actually really good at preventing the hyperalgesia effects of the opioids. And you'll see that's why we're giving a lot of these small doses of ketamine to our patients. So Decadron, it's a steroid anti-inflammatory. Meta-analysis showed that when we give it as a one-time dose, either preoperatively or intraoperatively, that these patients have a 10% reduction in their post-operative opioid consumption, and they have shorter stays in PACU. We also give it for nausea. It's good at preventing that. The dose we usually give is 8 to 10 milligrams, and they found it's most effective when giving the 0.1 to 0.2 milligram per kilogram, which usually comes out to that 8 or 10 that we don't normally give. NSAIDs, so these are all COX inhibitors, which you guys will probably usually see as Toradol. We either give it IV or IM. A meta-analysis of 27 different studies showed that when comparing the Toradol group to a control group, that there wasn't an increase in post-operative bleeding. This is kind of a theory that a lot of surgeons have, and a lot of surgeons won't let us give it, but now they're showing that it doesn't increase bleeding at all. This is kind of a heavy slide. It just kind of shows how COX inhibitors work, and they cause some different bad things, which sometimes we won't give it to the patient with cardiac disease. NSAIDs in general will increase the risk of stroke and MI postoperatively, more so if they're on it for a long-term basis than a one-time dose. Also, if patients have kidney disease, we usually try to avoid it because it causes vasoconstriction in the arterioles going to them. Lidocaine. So you see lidocaine a lot. We use it for a lot of regional, or most people believe that's how we use it, but intraoperatively we use it as a bolus whenever we're doing our induction. So you'll see in the charting we usually give anywhere from 50 to 100 milligrams up front. What this does is kind of block that sympathetic response to laryngoscopy. What we can also do with it, though, is we can put them on a lidocaine drip. Lidocaine has analgesic, anti-hyperalgesic, and anti-inflammatory properties. And so what they found is when we put people on lidocaine drips, that they have a 30% reduction if we run it intraoperatively in 1 hour in PACU, and they have an 80% reduction in opioids if we run it for 24 to 48 hours. Ketamine, so ketamine's an NMDA antagonist. What we're giving it in very small doses. So typically, for hypnotic purposes, we give ketamine 1 to 2 milligrams per kilogram. When we're doing it for pain and to prevent hyperalgesia, we give it in the 0.1 to 0.5 milligrams. Typically, this comes out to 25 to 50 milligrams for a patient. And what they find is a 30 to 50% reduction in their postoperative analgesics needed when we give these small doses. Magnesium, this one actually also works on NMDA receptors. We give it as a bolus and then run it as an infusion. It's a little bit harder to do, so you may or may not see this one. Precedex you'll probably see a little bit more frequently. It's a alpha-2 adrenergic agonist, so it blocks the excitatory neurotransmitters from being released on these nociceptive or afferent pain pathways. It's synergistic with all of our drugs, so one of the drawbacks is sometimes they can come out a little bit sleepy as it kind of potentiates our hypnotics as well as our pain medications. Unlike the other hypnotics and opioids, it doesn't cause a decrease in the muscle tone in the upper airways. So it's good for patients, say, going underneath bariatric surgery or have sleep apnea, because they can still get pain relief and sedation without the dynamic collapse of their airway. Typically, it's given as either a loading dose. You'll see a lot of us will give it as a 0.5 to 1 mic per kilo over the case. with or without an infusion afterwards. And they found that just with the bolus, that there's a decrease in opioid consumption of 30%. They also found that these patients have less postoperative pain for the 24 to 48 hours rather than the hospital, less consumption through the PCAs. Gabapentinoids. So Dr. Noble actually gives these to all of his knees in pre-op. What they do is they act on the calcium channels and prevent the excitatory neurotransmitter release. And these patients have anywhere from a 20 to 60% decrease in opioid consumption afterwards. Beta blockers. So originally we were given beta blockers as opposed to opioids in order to just kind of control the sympathetic response to surgery. Later what they're starting to find now is that beta blockers themselves have some type of inherent analgesia effects. They're not really sure how it works. Beta blockers work on G proteins like opioids, and so there may be some type of crossover there. Or they also believe that it decreases the sympathetic afferent pathways in the brainstem. But patients that get beta blockers either intraoperatively and at home, New England Journal of Medicine just came out with a study where they're showing that patients that take beta blockers for hypertension in addition to opioids for arthritis actually need less opioids and have less pain, which is just kind of interesting. This is just kind of a different way to do anesthesia. It's just a recommendation. So during an induction phase, like we talked about earlier, using short-acting beta blockers as opposed to fentanyl, and then during our maintenance phase, using beta blockers and different techniques as opposed to opioids. And then when the patient is actually starting to have pain, titrating in the opioids that we need.
So, preventing PONV is a huge part of ERAS. So there's a risk assessment that we can go by. There's some charts that give us the percentages of how likely a person is going to have nausea and vomiting. Some of the risk factors include history of PONV or motion sickness, being a female, non-smoker, and surgical procedure lasting more than 60 minutes. Also use of inhalation agents and opioids. So the AFL score assesses the patient on these risk factors. So here's the chart, and it gives you each of the components and the number of risk factors that you have, the percentage of incidence, and maybe a preventative strategy. So for just female gender, they're suggesting just the 4 milligrams of the dexamethasone and a second antiemetic. A lot of times we'll use Zofran, that's a big one that we use, or we'll do the ZZR. But as your risk factors go up, the increase of percentage is pretty large. A lot of people do have that, and of course using the opioids over 100 mics, which is pretty much every case that we use, they're going to have some kind of nausea and vomiting. So we try and hit all the receptors that we can to prevent that from happening. So some of the strategies to reduce the risk is to use propofol, use Tiva only, not use gas, avoid nitrous, and minimize our opioids using the alternative methods that Brian was just talking about, adequate hydration, and avoiding excessive fluid. So here's some of the pathways or the causes and the pathways that they go to in the brain. So for instance, anxiety or raised ICP, that can hit the GABA and H1 receptors. Chemotherapy, colitis, you're looking at the GI tract, which is the 5-HT3, HT4, and D2. Also the chemoreceptor trigger zone in the brain, that's the D2, 5-HT3, and NK1. And the acetylcholine, the muscarinic, is in the vestibular neuritis. So they all lead to the vomiting center in the medulla. And so to reduce and to hit all these receptors, scopolamine is the anticholinergic that we use. H1s we don't use as much as we do the H2s, which is the Pepcid or Zantac. 5-H2, we use the 5-HT3, the Zofran. Blocking the mu receptors, which is the opioids, and then the NK1, which I'm not sure if you guys have. I was told that you guys don't have a Prepotent here, which is called a MEND, which is an NK1 antagonist. So here's a chart showing the different drugs, the class of drugs, the type of dosage that we typically give, and when the best time is to give these medications to prevent nausea and vomiting. So a lot of times we will use the ZZR at the beginning of the surgery, but it also can be used at the end of surgery along with the Reglan here at the end. Dexamethasone has some kind of funny side effects, especially on women, so usually we don't give that before induction. So normothermia is a huge part of ERAS. It definitely is important to keep patients normothermic. It helps to decrease oxygen demand from shivering postoperatively and improves healing and decreases risk of surgical site infection. The temperature should be maintained above 35.5, and we use bear huggers, warm blankets, fluid warmers, HMEs. And I pulled this from the Stanford School of Medicine, their colorectal protocol with ERAS elements. And this is quoted from their website that the OR temperature should not be lower than 25 degrees Celsius or 77 degrees Fahrenheit when the patient enters the room. Yeah. So,
Good luck with
I know, but
PACU should be.
this is because it's important
It is
for
very important.
for the patients. We're
very important.
looking out for the patients, not
Hence is why you see I grab the bear hugger. One of the first things I grab is a bear hugger.
absolutely. It's
Mhm.
too cold. There was one time in the OR it was 59 degrees in there. That's not good for anyone. So anyway, this is very important. I don't know how else this could be incorporated, but things that we do to prevent, I guess that's all we can do. So growing evidence suggests that ERAS contributes to improved patient outcomes, reduce complications, accelerates recovery, get these patients out sooner, and that all leads to increased savings. So all these are beneficial to the patient, but sometimes patients aren't always going to be candidates for all of these protocols, or maybe they're candidates for some of the protocols, but not for others. So this is something that people can pick and choose what they're going to incorporate depending on each patient. So this all kind of summarizes everything: patient education, meeting with the surgeons, talking about either limiting fasting, carb loading, using regional anesthesia. During surgery, we're going to try and do our best to keep our patients warm, to minimize opioids when we can, not give fluids if we don't have to. Post-surgery, early removal of tubes and drains is important. Early transition to oral pain medications and early allowance of food intake. And this all shows better outcomes with increased patient satisfaction, decreased perioperative complications, decrease in hospital stay, and an improved use of hospital resources. So all of these components help contribute to ERAS. There's a lot of different things that we can choose from. Again, we don't have to use everything, but using as many as we can will help the patient, will help the hospital, will help us as taking care of the patients. So here's a sample of a protocol for breast reconstruction. So the surgeon can check off what they want the patient to have, can have a light snack up to 8 hours before surgery, may drink clear fluids up to 3 hours, confirm that the patient drank the carbohydrate juice, and then the aprepitant, the COX-2 inhibitor, they do have hydromorphone in here, which, of course, they're going to have, some pain medication, and then the gabapentin, the gabapentin ones that we talked about earlier. And then this is Dr. Noble's protocol for total joint replacement, and this was implemented last week. So he incorporates the carb loading, the carb drink loading, and up to 3 hours prior, he wants his patients to drink Gatorade. And then the pre-op medications that he uses are alternatives to the opioids. So this kind of incorporates a lot of the ERAS elements of limiting the preoperative fasting, using the alternative pain medication, and so I think that's a good thing for these patients. Some of the anesthesiologists in our last meeting brought up the point of, well, what happens when a patient gets canceled and they move up other patients? So these are all things, if they've just had their Gatorade, then it might mess up the schedule a little bit. So that's definitely a consideration to think about. But that'll be, I guess, have to talk to him about that. So, and that's it. So
Thank you.
Yeah.
Thank you.
Hope that was informative for you. Do you guys have any questions?
I'm working to get the ethical score on applications and forms fast, so that should be in the next few weeks.
Okay.
For all the patients.
Dr. Mabaden,
So
please
you guys
dial
will have that on your sheet.
8592.
I'm assuming
Dr.
you gave that to
Mabaden,
Dr. Rosella, did they